Thank you very much. Good morning, everybody. I'm happy that the title is Progress because, in fact, we have made progress, and I think it's important for us to know where we are with this field. I don't have relevant disclosures to our work in dysplasia and cancer prevention. So in order to understand what we're doing in cancer prevention for the patient with inflammatory bowel disease, and specifically the patient with chronic inflammation of the large intestine, we can break it down into some different components of a formula. And when you look at the research and the available evidence, they fall into the different categories here. The first is understanding who's at risk and how we might measure or quantify these risks in a more accurate and appropriate way. The second is to accurately identify precancer. That's what we call actually secondary prevention. If you're looking for precancerous changes as a way to then choose a patient for intervention, you need to be able to detect it, you need to do it appropriately, and you need to do it efficiently. The third has to do with having an effective prevention strategy. Now, in the ideal world, we would prevent all neoplasia in our patients with chronic colitis, and therefore that would be primary prevention. But the reality is we don't have very much information to truly guide us, or certainly not enough to change practice yet. On the other hand, what we've been doing has been recommending colectomy for confirmed dysplasia or early stage cancers in our patients. And more recently, we've come to appreciate the value of removing raised lesions or recognizing that low-grade dysplasia may not have the same predictive value it once did. We'll talk more about that. And of course, what we want to think about is the outcome of interest. If I was giving a talk like this in an oncology meeting, they would laugh at our data because we have no studies that show 5-year follow-up and outcomes in our patients in any prospective way, looking at mortality. Thankfully, we don't do that because we don't see it very often. But we'd also like to think about perhaps saving the colon, and importantly, as we recognize the outcomes of patients who have continent reservoir J-pouch creations, the quality of life of those individuals is part of what we can think about. So there's a lot of different variables here, and I'll do my best in the remaining time to update you on the field and give you some practical pointers. I've divided the updated risk factors for dysplasia and colorectal cancer in UC, and we often extrapolate to the patient with extensive Crohn's colitis into those that I've listed as modifiable, or at least potentially modifiable, mostly related to the degree of inflammation. Whether it's the increased inflammatory activity measured by all the different means that you know and that Gary reviewed some of the endoscopic indices, or whether it has to do with other markers of inflammation like backwash ileitis, which may in fact be just an extension of pancolitis, the pseudopolyps, which we often think of as being the healing of severe colitis, prior dysplasia in a patient who may have had it prevented otherwise, or a mass and stricture, which we might remove or think of in a different way. And then all those risk factors that may not be modifiable. Male sex, gender is actually assigned and can be modified, but sex isn't. Longer duration of disease, greater extent of colonic involvement, although you could argue maybe we could modify that in the future. Family history of colon cancer, independent of a family history of IBD. Of course, PSC, although we don't understand that mechanism, that's a strong risk factor. And younger age of diagnosis, which may be related to disease activity but hasn't been clearly sorted out. Now we can summarize most of what I'm going to say to you in this nice table, which goes downward in the first column in our progress by diagnostic modalities, from the early days of physical exam through barium enemas, through fiber optics, our digital scopes to high-def scopes, and then chromoscopy. And depending on how good our modality is, you can think about what the primary lesion is that was found, whether it was as bad as metastatic disease with an outcome of death, masses or tubular colons that had patients with early stage lesions and cancers detected too late, to the more recent identification of flat lesions, lesions that we sometimes called invisible but now can see, and the recognition that as we've gotten better at finding things at earlier stage, we've moved from prophylactic colectomies to just sending everyone to colectomy, to recognizing we can resect specific lesions, we can follow up with more intensive surveillance, and in fact we've moved away from random biopsies towards recognizing the importance of active surveillance in at-risk patients. And that's the main theme of what I'm going to present for the next few minutes. We've come to realize that random biopsies, even if they're really random, although most of us know that what we're saying is random may be guided by something we're seeing, are of very low yield and inefficient. In addition, from 2 different retrospective analyses in an era before high-def scopes, most dysplasia was visible with white light, both in the UK and in our study in Chicago. And we've also recognized that there's different predictive values for patients who have dysplasia but don't go to colectomy. Again, retrospective analyses of a small study from our center, there's a similar study from New York and other work that's been done in other parts of the world, that these patients, for whatever particular reason, didn't go to colectomy, whether it's because they refused or because the clinician had some other sense of what was going on. We realize that there is some progression, but it's not as high as we once thought. And in fact, raised lesions, which we think of as being removable or looking a little more like polyps in the non-colitis patient, when they're removed, have a lower risk of progression over time from those that are flatter. And maybe there's a different biological behavior here that's explaining that. Nonetheless, it gives us some more information about how we might stratify follow-up. We can't ignore the very important fact, which is that we rely on our pathologists to help us, and we also rely on how we communicate to the pathologists to help them. And so we have to give them adequate biopsy specimens. We need to biopsy areas of normal-looking mucosa to better characterize how extensive the disease is. We have to label our samples as being the lesion of suspicion and the area around that lesion. And we also recognize from this now old study, but some more recent work that's been done, that our pathologists are actually pretty good when there's no dysplasia, and they're very good when there's high-grade or even cancer, although that wasn't included in this old study. But where they have some difficulty is in their agreement, even among themselves, meaning when the same pathologist reread the same slide in calling low-grade and indefinite. So this answers the question that I used to ask, which is why don't we have a second review by another pathologist for all of our surveillance biopsies, even when they're negative? And it's because they're pretty good when they're negative and you don't have to worry as much. But it is important to recognize the limitations of your pathologist or make sure you have some quality measures in the way this is read. So what we've started to realize now is that this really isn't your father's Oldsmobile or your mentor's dysplasia, and only the older people in the room get this ad, but enjoy it. And it's not the Pittsburgh bus, but this is the Chicago Oldsmobile, okay, Miguel? But the old dysplasia was called invisible. The new technology make most of it visible. And the hypothesis, therefore, is that dysplasia found by newer technologies may not have the same meaning as that which was found in the past. And the proposal, therefore, would be that we could have a different approach to detection and follow-up. In other words, if you can see more, you can be more confident you're not missing advanced lesions and therefore not sending people to surgery immediately as a reflex any longer. We also need to acknowledge, and I want to make this point very clear for the audience today, that despite the fact that the term DALM was coined in Chicago by some of our old teachers and colleagues, Susie and I know very well, the reality is that we're not using those terms anymore. We want to be more descriptive. As we've gotten better at seeing things, we need to be careful how we describe them. So it is just about polypoid lesions that you see. We're encouraging our pathologists to use the same terminology. Polypoid low-grade dysplasia, as opposed to calling it an adenoma, calling these things adenoma-like masses, et cetera. And then those lesions that are either flat, which means they're not raised, and we can start adopting some of the other terminology that we use in non-colitis, or truly invisible would be when you do a random biopsy in an area that you're worried about and it comes back with dysplasia despite what you've looked for. Try to get away from using DALM and ALM because those terms have been confused and they certainly are being phased out by all who are talking about this. Now, when you've seen the dysplasia, that means visible by white light and raised, and you've removed it completely, in general, we acknowledge that in the absence of other dysplasia with a careful exam, this is somebody who can have ongoing active surveillance. And when it's flat, which does not mean it's necessarily invisible, but rather diagnosed by chromoendoscopy or not raised otherwise, it might be something you found when doing random biopsies, but more often these days it's a flat lesion. Maybe you've resected it, maybe you're not sure. If it's unifocal, the general recommendation right now is you can intensify surveillance. If it's multifocal or if there's other risk factors that make you concerned, this is somebody who should be referred to your surgeon. And certainly if it's high-grade dysplasia, we're still not comfortable watching those patients when you found flatter lesions. So this is something for you to think more about, and there's now going to be evidence, I hope, at DDW to back up some of this. So stay tuned on that. Now, what all of you want to know is, should you be doing chromoendoscopy? And I'll tell you that this presentation is meant to be part one of a two-part presentation, because in the next session, I'll be showing you examples of chromo and some videos. So if you want to learn a little bit about how that works, you can certainly stay or come back for that session. I will tell you, though, to get to the bottom line, is that chromo's not for everybody, and I don't want you to leave here thinking that you need to do it tomorrow. There's some limits to what we know so far. Nonetheless, in the tandem colonoscopy analyses in which dye spray chromo with either methylene blue or indigo carmine was compared to white light, it is consistent among these studies that chromo finds more dysplasia. It's more sensitive and specific, so you can do targeted biopsies and be more confident. The challenge, however, is that there's some unexplained parts of this. One is, if we're finding more dysplasia by chromo, where has all the occult dysplasia and cancer been that we've been missing all these years? As any experienced clinician in the room knows, you're not having patients pop up with cancers who are under your watchful eye through surveillance programs. So either this means that we're finding earlier stage dysplasia that doesn't progress and therefore has a different predictive value than dysplasia that we used to find by our earlier technologies, or there may be other explanations for it, like the intervention of surveillance has actually been working all along. We only have one study that has any follow-up. This was Jim Marion's study from New York, and now he's at Sinai, in which the patients who ended up going to surgery for unresectable low-grade dysplasia, none of them had cancer. I think that's an important piece of information. Although small number, we should recognize that in the past, low-grade dysplasia that prompted immediate colectomy had as high as a 19% risk of concurrent adenocarcinoma. So it again suggests that what we can see in the modern age may have different predictive value. Which dye should you use if you're going to use chromo? And again, I'll talk more about this in a little bit in the next session, but I want to go through a few things. Methylene blue, when given IV, has a definite drug interaction with your SSRI patient. However, in talking to pharmacologists and some other folks that I work with, the amount that we use to spray the bowel does not seem to have that interaction. So it is not contraindicated in our many patients who are on SSRIs who come to us and may have methylene blue spray. There has been this question of whether or not it's carcinogenic based on some small and more animal-based data that it causes some DNA damage to colonocytes, although that remains theoretical in the human population, but of concern for some. It's an absorptive and rich dye in its color, and I'll show you examples of that in the next session. It doesn't require that you have to move the patient around because it's absorptive and not gravity dependent. Its cost is comparable to indigo carmine, and earlier this year there was a shortage. Maybe some of you knew about that. Indigo carmine, on the other hand, doesn't have that drug interaction. It's not thought to be carcinogenic. It is a surface dye, so the staining is less rich. It does require that you have to roll the patient around on the bed a bit, and it's not quite as useful in my experience. Similar in cost, but it's currently on back order, at least based on our experience at the University of Chicago and based on this website that we accessed, and they're supposed to be more available by the end of the year. Now, in terms of the newer approaches to dysplasia management, we now recognize that some dysplasia doesn't require proctocolectomy. Polypectomy is sufficient in many patients. Endoscopic mucosal resection appears to be useful and appropriate in many patients. And there's even now some anecdotes and a small case series that's being reviewed related to endoscopic submucosal dissection, as well as subtotal colectomies for appropriate patients. But the level of evidence for all of this is weak. But then again, the level of evidence for most of what we do in dysplasia and colitis is weak. So there remain some challenges to chromo and IBD. The perception that it's time-consuming and expensive. It may not be as time-consuming as you think when you actually get good at doing it, but it does certainly add some materials. It may reduce the cost of your pathology parts of it, though. It's unclear if it actually changes outcomes of significance. I don't think we're going to have an answer to that anytime soon. Many patients may not qualify for it. Remember that about half of our patients may come to us in clinical remission for surveillance colonoscopy and have unexpected active inflammation in some part of their colon, either histologically or endoscopically. And we also know that despite our best efforts, many patients have a poor prep, which limits the use of dye as well. There's not good consensus yet in our field, and there's no training pathway or competency requirements. And in fact, despite those studies I showed you comparing to white light, they were not with high-def scopes. And those in the room who are using high-def scopes may wonder whether high-def with the current narrowband and the emerging newer version of narrowband may actually be useful in the future. Just don't have the evidence yet. What about billing for those who are doing it? Well, unfortunately, there's no CPT code for this procedure, nor is there one in the revised procedural codes, unfortunately. I use a 22 modifier, but you got to be careful that you document in your note that it was of a longer exam than usual or something more complex than usual. If you're lucky, that'll pay 10 to 20% more. of the allowable charge for the procedure, but it may also shoot you in the foot if somebody actually decides to look carefully and decide that it's not doing what it's supposed to do. There's also this 43499 code with a 59 modifier, but most of the time insurance will deny that, and I haven't used that one. Who will you consider it for? Well, there is a role for it in some patients. Maybe the patient with previous confirmed dysplasia, the patient who's high risk but can't go to colectomy or is refusing going to colectomy. That's a challenge, but make sure you're getting a second opinion from another colleague or and a surgeon, of course. Those lesions that are found and you want to clarify their margins, which I'll show you examples of in the next session, and the patient with minimal inflammation and a very good to excellent prep is key. And that's all from Frank Ferre's nice review that was in Gastro as part of the AGA technical reviews. Now, the challenge we face is that the better we get at finding dysplasia, the less specific we can be in terms of what's clinically significant. In other words, if you think about the lesions we used to see by just doing a barymenema or the lesions that are seen easily by white light, those may be more clinically relevant for making decisions than those that we now find by chromo, which are flat or minimally raised. And therefore, we may be actually identifying more lesions and losing our specificity the more sensitive we become. On top of that, this all requires more time and training, all of which hasn't been well defined. There's an ASGE course coming up in which they're going to try to tackle some of this, and I think Gary's one of the faculty for that, and I think Frank is as well. There has been a consensus meeting earlier this year that was funded by Family Foundation, and the consensus meeting started with a systematic review of available evidence and then had the experts from around the world vote on the strength of the evidence. And they came up with a few statements, and this is now being routed for publication, so stay tuned. And so I'm not summarizing the publication, but rather some of the general concepts. High-def scopes were better than standard def. Narrowband imaging was not better than white light, especially with high-def scopes. Chromoscopy was better than white light endoscopy, but may not be necessary for everybody. The newer technologies enable ongoing surveillance instead of colectomy when certain types of dysplasia are found, and there was a distinction made between follow-up of visible and resectable dysplasia and those that you find accidentally or by random biopsies. If you look at available guidelines, the AGA and ACG guidelines, which I've highlighted here, do not yet recommend chromo. And if you actually look at some of the language, it says the sensitivity for detecting with chromo is higher, but it's for endoscopists who have expertise, and that hasn't been well defined yet. So you should learn more about this, of course, but it's not something that you're necessarily going to be held to a standard to do yet. If you look at the ECHO 2008 and the BSG 2010, they both acknowledge this is important. BSG goes so far as to recommend it. And in fact, in the BSG guidelines, they say that you should start at 10 years, and this is the British Society, so take this with what you want. I'm not necessarily doing all of this, but I am adopting part of it. If you do pancolonic dye spray and the patient has no inflammation, they actually say you can go 5 years before you do another surveillance exam. I think most of us would be a little nervous about doing that. The most I let my patients go who are in really stable, deep remission is 3 years. And then they say that if there's intermediate risk with a little inflammation or a couple of risk factors, you might go sooner. So the general idea here is not necessarily to say that you adjust treatment to get them into a deeper remission, which we all want to know and talk about, but relatively appropriate, and maybe the other side of this is you stratify to their follow-up interval based on what you find when you do all this. So in the US, we still need some updated guidelines, which hopefully will come, clarification of quality measures, uniformity of endoscopy reports, and some improved techniques, and those are all in their way. One slide on future techniques includes the fecal DNA work that John Kissel and actually a multi-center effort, but led by John at Mayo, looking at some markers that did correlate. You all know about the fecal DNA markers for the non-IBD population. You may not have known that there's some evidence for this to help us in IBD, and then there's some other markers coming, and if you want to do a microscopic exam of the entire colon, it may not be practical, but you can find dysplasia when you do such things. So it's time to enter a new era of surveillance in cancer prevention and IBD. Despite the absence, or maybe because of the absence of updated guidelines, I think we can start thinking about individualizing our approach to our patients and applying some of these new techniques. So I'll end with what I suggest you do. Risk stratify your dysplasia in colitis based on patient and disease-related factors, including those individual risk factors in your patient, and as well as the willingness and ability to follow your recommendations. And remember that men do have a higher risk than women for their dysplasia and cancer. And then there are the dysplasia-related factors that I've covered today a bit as well, the grade, the morphology, whether it's raised or flat, the field effect, meaning whether it's unifocal or multifocal, and longitudinal follow-up. If you keep finding dysplasia on every exam when you're bringing that patient back, you really should be talking about getting them to a surgeon and having that recommendation. So I appreciate the opportunity to update you on the true progress that we've made in dysplasia and cancer prevention in our IBD population, and I look forward to the panel question and answer session. Thank you.